Fluid and electrolytes. Nursing 102. Welcome back, y'all. Common risk factors for fluid and electrolyte disturbances. Conditions. Are we out in the heat? Are we sweating excessively? Different conditions like that. Are we submerged in water? Can cause issues. Adverse effects from medications. Did we take too much Lasix, furosemide? Did we not take enough? Did we take too much sodium bicarb? Did we not take enough? You know, back and forth. And there's different adverse effects to different meds. We will go in depth into medications, but we'll do that in class and actually have an activity. Acute medical conditions, injury, trauma. If we get in a major car accident, lose a limb, we're going to have a major blood loss. That is a big fluid disturbance issue, right? Chronic medical conditions. Are we in renal failure? Are we in liver failure? Different medical conditions are present that can create these issues. This is a perfect little, I like this, visual. Symptoms of fluid volume deficit. Think D deficit. Decrease in weight. They're going to lose weight because they've lost volume. Part of what we weigh is the circulating volume in our system. Decrease in our skin turgor. If we check it, it's going to tint if we have a decrease in volume. But just remember, in the elderly, that is not always accurate because of their loss of elasticity in skin. So if it is, you can go to like the chest area and pinch to see, but I'm just saying there are other ways of looking in the elderly than the skin turgor. But for children and healthy adults, definitely skin turgor will decrease. Dry mucous membranes. Let's look in their mouths. You see dry membranes, then we know there's a volume issue. Decreased urinary output. Ding, ding, ding. This is a big one. We're going to see that. If you don't have enough volume inside, you're not going to be putting out volume per urine. Decreased blood pressure and orthostatic blood pressure changes. Definitely. Decrease in your blood pressure. Your blood pressure is going to go down. You're going to become hypotensive. If you are worried about a patient being dehydrated, do orthostatic blood pressures on them. Lay them down flat, then sit them up, then stand them up. And you will have definitely a change in those blood pressures that by the time they stand, it will be very low. So just make sure that you are always thinking safety. Don't let them fall down and hit their head or do anything to hurt themselves. Think safety. Decreased in warmth of extremities. They're going to be cool to the extremities because they're going to be trying to shunt volume and fluid to main organs to keep everything functioning to maintain homeostasis. Decreased fluid to the pump so the pulse will become elevated. If you don't have enough circulating volume, if you're dehydrated, if you've lost fluid, volume, blood, whatever, you're going to become you're going to become, not hyper, I'm sorry, you're going to become tachycardic. You're going to have high heart rate, fast pulse. You're going to be tachycardic. You're going to become hypotensive. So the heart rate's going to go up and blood pressure is going to go down. You're going to have decreased strength and pulse. Your pulse will become weak. It's going to become fast and thready. You ever hear that? That fast, weak, thready pulse? That is usually due to a loss of volume. Dizziness, lethargy, seizures, confusion, and coma. They're going to become confused. They're going to become dizzy, lethargic. But when you get to seizures and coma, you are behind the 8 ball. You are not going to probably turn this around very quickly, and damage will be done. That's why you need to be in tune to your patient, assessing all of the time and looking for these signs and symptoms. Over to the right, you see fluid volume deficit, mild, 2%, moderate, and severe. Findings. With dehydration, we are going to have elevated values. This increase will be an increase in your hematocrit, your BUN greater than 20. So things are becoming concentrated due to loss of volume. Specific gravity greater than 1.030. So our urine is going to have less fluid and higher solvents swirling around in that urine. Increase in your serum sodium level greater than 145. We're going to have water loss from fever, respiratory infection, and watery diarrheas can cause this. So the sodium levels will go high, and that makes us what? Hypernatremic. Your priority nursing interventions for fluid volume deficit. That means a decrease, right? DDD. Think that way. Fluid says fluids down there. Remember this little acronym. Fluid, increase your PO. Give them stuff, fluid by mouth. Give them something to drink. Do not give them anything to drink if they've had a change in their level of consciousness. They can aspirate and all that because we can what? Give them IV fluids, and we're going to give them isotonic, equal, right? If we give isotonic fluids, that means we're not going to get a fluid shift. We're going to maintain volume within the system because we don't want to shift any electrolytes at this point. We need to give the volume and allow the body then to equalize itself out, right? Become homeostasis again. Blood. If they've lost blood, you need to give blood. If it's a traumatic injury, you can give fluids to start while you're waiting for blood to come. But blood loss equals blood return. We need to give blood if we have a blood loss. Level of consciousness. They're going to start to change. They're going to get confused. You're going to start to see those changes. They're not all there. They're going to become anxious. They're going to become have impending doom. Patients will be like, I don't think things are right. I think something's wrong. They'll feel that. Then they'll get confused. Then they get anxious. Everything. They're moving around a lot. Look at their output. At this point, you probably will see a decrease in urinary output. If not a huge one, if you're doing hourly, then you're going to see a trend if you're doing every so many hours. But I will say this, even if you're not ordered to do hourly intake and outputs, a good nurse will say, I'm having this issue, so I'm going to start to watch their output more carefully. I'm going to start looking hourly. Let your CNA know if they are getting your volumes for you, your intake and output. Let them know you're having this. Can you please tell me what, Miss Jones is having each hour in urinary output? Will you empty that for me? And if they can't, then you should, because that is a trigger to let you know something's going on. Urine less than 30 milliliters an hour is ding, ding, ding. You need to remember that no matter what. You need to report it to the MD immediately. If you have 30 milliliters or less an hour, you should call a physician, because under that, 30 is the magic number. Under that an hour, your kidneys aren't functioning and bad things are going to start to happen. And trending decreases. If you have 500 out, and then the next hour you have 300, and then the next hour you have 100, and the next hour you're down to 50, and the next hour you have 50, is that a trend of decrease? Yes, definitely. And you would want to let a physician know that so that they can order fluids or change something that's going on. IV fluids is ordered. If you get an IV order, if you get fluids ordered by your physician, those need to be started immediately. Lots of times people go, oh, I need to hang a bag of normal saline on that patient, and they think nothing of it. It's like nothing. But the truth is it's important. That order is given, and you should get those up as fast as you possibly can. It needs to be done immediately. And strict INOs, like I said, that is your ticket. What's going in and what's coming out. Should always be about equal. But I'm going to say this. If you don't have a lot coming out, then something's happening with the in. And it's something happening internally. And so we want to increase the in so we can increase the out. Always think that way. Document your vital signs. What are we going to see? Hypotension and weak pulse, right? And they're going to become tachycardic. Their heart rate's going to start to go up, and it could be a gradual and then all of a sudden. So you want to watch for these signs. They can slowly be happening if you're watching your intake, your output go down. your blood pressure start to go down, your heart rate start to go up, you need to think that these patients are becoming dehydrated or there's a volume deficit. And put them in shock position. And shock position would be flat with legs elevated. Lots of times we want to put them in reverse Trendelenburg. And that used to be the thing we did. That was like we throw them into reverse Trendelenburg. But evidence-based practice has proven that that is not a good thing for your patient. It's actually more harmful than helpful. So lay them flat though. Put the bed flat, and if you need to elevate the feet, you can do so with pillows, or you can do the leg gatch. Do you know what I'm talking about? Where we'll gatch those legs up, but put them in a flat position. If we set a patient up that's hypotensive and has volume issues with tachycardia, we're going to only make their heart rate go up further, which will make their blood pressure go down further, and we cause more problems. You can study this. I'm not going to read it to you, but it's great. It goes back through this again, and you want to watch these things, and this is part of your assessment, and you are assessing every minute you are working as a nurse. You assess what's going on with the patient, you assess what's going on in the room, you assess what's going on with the family, you assess what's going on with the body system, what they're doing, whatever. It's a constant continual. And when you get into that mode, you'll be sitting in church one day or sitting out at a public event, and you're going to go, look at those veins on that person, because you have assessed them from head to toe. You're going to say, liver issues, I can already tell just by their coloring or whatever. You will get there, and you already are doing it, and I know you are. Drugs. There are a lot of drugs in this unit module. So what I'm going to tell you is this: we are going to have an activity, and we will go over drugs, and you will understand and know what you need to know and the reason behind them. But I'm not going to go into detail in this. Causes of our fluid volume excess. Heart and renal failure. What happens? We swell, don't we? We have third spacing out of volume issues. Cirrhosis of the liver. We have portal issues, don't we? Which causes fluids to shift, and that's why we get that big distended belly, swollen, third spaced, portal hypertensive looking body. Elevated serum sodium. Think about it. Elevated aldosterone secretion. We're going to have a decrease in their albumin, which is our protein, isn't it? And NSAIDH. And you should have learned about that, and if not, please remind me in class and we'll go over it. Excess. When you have too much, where you're losing too much volume, one way or another. So when we have too much hypervolemia, fluid volume excess, we're going to have an increase in blood volume or circulating volume, okay? So our pulse rate's going to go up, our temperature is going to go up, our blood pressure is going to go up, we're going to have increased edema, ascites, we're going to have fluid overload back up, everything's going to go up. See the arrows going up? That's what happens. We're going to have a decrease in hematocrit this time around. And the reason why is because we're diluting out what's in that circulating volume. Our serum osmolality is going to decrease, right? It increases if we have loss of, or we decrease in the volume. We have more solvents, different things floating around, and that serum osmolality, and when you think serum, you think blood, it's going to decrease. It's now expanded out too much. Decrease in sodium and or potassium, depending on what's happening. And a decrease in the BUN is going to happen because of hypervolemia. Picture of fluid volume excess. And this is, you're going to see different things. We're still going to have those neurological changes. And that's why you just can't depend on neurological changes to go ding, 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 this is what's going on. But what you know is if you have a neuro change, something's going on. And you need to be then looking further in. I always say that where Nancy Drew or a detective of some form, and we're looking to solve the mystery of what's going on. That's what nurses do. Good nurses are detectives. They try to figure out what's going on. This is a great little picture to look at and to help you see. Priority nursing interventions for fluid volume excess is restrict. Reduce the IV flow, evaluate your breath sounds and your ABGs. We want to look to see, because if we're not perfusing well, oxygenating well, we're not going to have great ABGs, are we? Be respiratory issues. Semi-Fowler's position. These people we need to sit up because they're going to drown. See his little body over there filling with volume? That's what's happening. They're drowning. Treat with oxygen and diuretics. Reduce fluid and sodium intake. INOs and weight, we want to watch it. Circulation, color, and presence of edema, and turn in position every 2 hours. We don't want everything sitting and you leave a patient on their back, what happens? All of it goes to the back, doesn't it? Right, all that volume swelling, everything, they're going to have a lot of issues. So we need to turn them to keep the lungs, keep volume moving, keep volume moving. We don't want things to become stagnant. Homeostasis versus electrolyte imbalances. I love this. Homeostasis, electrolyte imbalances. That knocks your rocks off. Okay. Hyponatremia. No water, no salt. Gotta have it. Dry as a desert. Means low sodium. Hyponatremia is sodium less than 135 milliequivalents per liter. You're going to have a decreased blood pressure, decreased muscle strength, decrease in deep muscle reflexes, a bounding pulse, apprehension, you're going to be apprehensive, confusion and lethargy, and seizures. And people that are severely hyponatremic, we want to slowly give them sodium back because we can cause some shifts within the system that can actually kill them. So you want to be very careful, especially with any kind of IV solution trying to change this. As a nurse, always be on high guard. And you can see different things that can cause. And I love this over here. These are the best. I am a visual individual. I like to look at pictures. It helps me. I don't know why. It might not all of you, but a lot of you, I think it can help put it all together. Okay? Sodium deficit, hyponatremia. We've already said that. We'll have a decreased serum sodium level. That's blood. Decreased serum osmolality. And a decreased specific gravity with hyponatremia. Priority nursing interventions for hyponatremia. Sodium. They need salt. Right? And look at to the side, sodium. Sodium intake increase. Seizure precautions. Your patients that have hyponatremia, you should put immediately into seizure precautions. What does that entail? Yeah, we can put things on the side rails to protect them in case they have seizures. Make sure that we have airway interventions nearby. Used to in the day, we would tape up bite guards up so that if they went into a seizure, we'd try to put a bite guard in their mouth. That is not really recommended anymore. Some places still do that, but you definitely want to make sure if they're going to seize that you have something to protect them so they're not beating themselves against rails or anything that can hurt them. Side rails up, bed in low position, all of those safety issues. Overload, restrict fluid intake, right? Daily weights, intake and output. Use isotonic IV fluids to restore. And monitor for postural hypotension, increased heart rate, dry mucous membranes, and change in level of consciousness. Loads of sodium. They've got loads of sodium. Low water intake, osmotic diuretics, diabetes insipidus. We're going to see this. Excessive water loss, and sodium intake too much for meds or meals. So these are people with too much salt. They have loads of salt. And I love that picture because isn't that the truth? Assessment of hypernatremia. We're going to have an increased pulse, increased muscle irritability and twitching, increased thirst. Dried out from too much sodium. We're going to have a decrease in your urinary output. You're going to have dry mouth, restless, irritable, progressing to confusion, increased fluid retention, edema, and deep muscle reflexes will be increased. Laboratory findings for hypernatremia. Increased values. We're going to have increased serum sodium. Your blood level, sodium level is going to be elevated. Your osmolality will be increased also. Priority nursing interventions for hypernatremia is sodium. Think sodium. Sodium intake, decrease it. Don't let them add salt to their diet. Don't you look, are you running sodium, normal saline in, sodium chloride 0.9%? Are we running that in at excessive volumes and they don't need it? Oral hygiene, right? Diuretics, loop diuretics. We don't need to pull any more fluid out, do we, at this point? Increase your water intake. We want to dilute the sodium levels. Use hypotonic and isotonic fluids. Monitor for adequate renal output to make sure that they're voiding and urinating what they should. Okay, sodium.